So I would start off by giving those aspects of ECMO which are relevant to heart transplant, talk about those aspects of heart and lung transplant which have a relationship to ECMO, the pivotal role ECMO plays in cardiopulmonary transplantation, and wind up with our experience. So as you all know, ECMO is a versatile tool which can be instituted in the bedside and it can be provided for extended periods of time, providing both heart and lung support. It plays a pivotal role in heart-lung transplant, and I would even go so far as to say it's a mandatory requirement in transplant units, especially units which perform lung transplant. So coming to heart and lung transplant, any end-stage lung or heart disease where all other therapies have failed, you look at a transplantation, either an isolated heart, isolated lung, or if it's a combined disease, an isolated heart and lung transplant. The thing we need to keep in mind is the concept of disease of transplant. Although we transplant the patient, we are giving him a disease of immunosuppression. Now that has to be borne in mind. And so we think of a transplant only when we have thought about, considered, and found to be futile all other non-transplant options. In other words, it's a salvage operation. Having said that, to date, heart and lung transplant still remains the gold standard for end-stage heart and lung disease in appropriate patients, although perhaps the future might see devices playing a greater role. Let's delve a little more deeper. So talking about recipients and donor organs. Organs, as we all know, are scarce and precious, and therefore it's incumbent on us to have a proper use of these organs. And so we need to look out for patients in whom, when we implant these organs, they have a higher likelihood of successful outcome. So that brings us to bridging therapy. So to that end, that we choose our recipient who get appropriate recipients for the transplant, we need to keep them in a good state of health until such time an organ is available. Not everybody are lucky. There are patients on the waiting list who deteriorate and fall off the perch while waiting for an appropriate organ. Now what happens in a case of a heart or a lung is there is effects on other organs. The kidneys go off, the liver go off. So we need to preserve and maintain the prospective recipient so that when transplanted with a rare and a precious resource, the outcome is good. Now here comes mechanical circulatory support, and we can bridge them with mechanical circulatory support. So now, if you delve deeper into ECMO, no doubt it is invasive, and it is not without its problems. You have problems of bleed, you have problems of infection, it is labor and resource intensive, and we in our unit have shown that patients can be maintained for a prolonged period of time, running up to even months, safely until such time they have a transplant. So what we need to do here is to do a risk-benefit analysis. What are the benefits the ECMO is going to confer on the patient, keeping him alive, keeping him in good status to have the operation, versus the risks that I have enumerated above. Now, when the risk-benefit analysis is skewed towards benefit, we would think about a bridge to transplant. Now, I'm going to talk a little longer on the lung transplant in interest of time, and of course, cover a bit on the heart as well. So in lung transplant, the role of ECMO would be, one, preoperatively, what I just talked about, bridge to lung transplant. In some cases, it could also be a deathbed rescue. Intraoperative use, we tend to preferentially use VA ECMO to cardiopulmonary bypass, and postoperatively, ECMO comes in very handy. It comes in handy as a rescue therapy to salvage the graft. Now that's our activity data of, until the recent transplant we did a few days ago. I would like to draw your attention right down to the double lung transplant, BTT, that's bridge for transplant. So we've had about 20 bridges for transplant out of a patient number of 72. Total of 221 organs, 221 lungs in different combinations of isolated lung, either a single or a double, heart and double lung transplant. Now, if you look at the bridge to transplant, 20, which is not the last, but the one before that, 16 are ECMO, and 4 are bridged with mechanical ventilation. So, bridging a patient prior to lung transplant, once the indications are met, normally we tend to ventilate them, and as I had spoken earlier, as much as a third or even 40% of patients with ILD, end-stage ILD, have got such stiff lungs that you cannot ventilate them and they need ECMO. And once we institute the ECMO, we tend to extubate them, keep them awake, because we find it improves the morale, it allows oral feeding and communicating. As you can see here, you can see the ECMO console right down, and that is a patient awake, and we are encouraging him to do incentive spirometry. This is yet another slide emphasizing the importance of maintaining physical therapy. Now that's a patient on ECMO who's having what we call a LETO device to keep his lower limbs active. So the bridge to ECMO was done first in 1975, but since 1991 you've got successful transfers, and subsequently many centers across the world use ECMO. There's plenty of evidence which says ECMO to lung transplant is very good, and I'll just highlight a case. There was a patient who was worked up for lung transplant, shifted to our facility for a possible transplant. However, he deteriorated, ventilated him, couldn't ventilate him, and so we had to do a VV ECMO. Now that's his X-ray and his CT scan confirming an end-stage lung disease. We extubated him, and that's him here. I've got his permission to use his picture where he does spirometry, and that is the transplant, post-transplant chest X-ray. He is a prolific writer, so he goes on and writes a book and publishes a book. No doubt I have his permission for the slide, and he published a book called Who Took My Breath Away, where he chronicles the personal experience of getting really bad when he was ventilated, how he spent 12 days on ECMO, and then the road to recovery. It's a book worth reading. Single lumen VV ECMO. So normally ECMOs, you need to have an input cannula and a draining cannula and a return cannula. A single cannula, I beg your pardon, I've made a mistake here while making the slides this morning. It's a double lumen single cannula. I apologize. It's a double lumen single cannula where you have just one cannula, most often through the internal jugular vein. Now once you establish ECMO, you're able to mobilize him. You can move on to even ambulate him very well until such time he gets a lung. Now, intraoperative use of ECMO, I'm not going to dwell longer. Suffice it to say that we use less heparin, therefore there is less bleeding complications. Post-lung transplant ECMO. So we've done the transplant, we're all very happy, but then the lung stops working, commonly due to two reasons. One is a primary graft dysfunction, which can be mild, moderate, or severe. Basically, it is a lung which is not functioning, but it is not due to rejection, it is not due to infection, it is not due to pulmonary edema. So we believe it could be due to a reimplantation response or probably an ischemia reperfusion injury. So when you are confronted with a severe grade 3 primary graft dysfunction, we do know that if these patients are supported and allow time for the lung to recover, those organs can be salvaged. So that's one indication. The other one is patients who develop sepsis, no doubt because of the immunosuppression, and a following ARDS can also be dealt with by ECMO. So bridging to lung transplant and rescue post-transplant, of late there has been increasing role of ECMO. 5%, the data says, require a rescue ECMO. Importantly, 96% of these can be weaned off. In our experience, we had 11 cases of severe PGD, out of which 7 needed ECMO. We were able to salvage 5 who were successfully weaned and discharged. 2 did not respond and succumbed to the problem. Just a few pictures. Yes, that is a chest X-ray. and you can see two cannula from the groin. One is the draining and the return cannula. Day 5, day 8, you can see things are clearing up, chest X-ray is clearing up, and come day 13, which is the 24th post-operative day, we were able to completely take him off ECMO. So you can compare the two X-rays of the same patient. The one was an ARDS following lung transplant, and that was a recovered, salvaged organ after ECMO. So ECMO and heart transplant in 3 scenarios: pre-transplant, pre-heart transplant, immediate post-transplant, or late post-heart transplant. So the scenario A for a pre-heart transplant is one, a patient could be in acute cardiogenic shock, commonly after myocardial infarction. Or the next thing could be a patient with end-stage failure on the waiting list who falls off the perch. So a cardiogenic shock could well end up, requiring CPR, then we put ECMO, and then after prolonged periods of resuscitation, we are not sure how they are, so we use it as a bridge to decision making. One day, completely support the organs, turn the sedation off, try to wake him up, get a neurologist to examine him. If there are signs of irreversible neurological damage, we do not continue further. You can't make this decision after 1.5 hours of CPR and you're not sure whether you can continue or not, because no one knows what the condition of the brain is. ECMO allows us to get the circulation in order and then give time to wake up and see. Now, in those patients whose brain is good and they awake, you can bridge them to a more durable assist device and then bridge them to transplant. So the data says as much as 44% of refractory cardiogenic shock can be salvaged by ECMO, in that half, when you revascularize, they get better, and the remaining half require heart transplant. So we had this patient who had a percutaneous catheter intervention, had a cardiac arrest, ECPR, VA, ECMO, and on ECMO we did 2 grafts. We weaned him off ECMO through an intra-aortic balloon pump, finally got him off that, but he remained to be in heart failure, listed him for heart transplant, got his heart transplant, and he is well. The data says that in VA ECMO for cardiogenic shock, more than a week, the results are, the mortality is 80%. However, we need to go back with our extensive experience in ECMO. This could be probably even lesser. Myocarditis, the myocardium is known to recover in 14 days. We need to wait for that. So this is another patient who had an LVAD for a year, and then he had a heart transplant on the availability of transplant. Now, if you put a patient on ECMO and directly transplant him without VAD, what are the results? Not as good as compared to VAD. So the 1-year survival for a direct ECMO to heart transplant is 55%, whereas if you compare it with VAD, there was this study by the UNOS registry of 107 patients. Those who were bridged from ECMO, the survival was 73% compared to a VAD bridge. Those who are bridged from a left ventricular assist device was 93%. Post-transplant ECMO, early and late. Early again, PGD, the same primary graft dysfunction which I told lung, affects the heart too. It could be either PGD isolatedly affecting the right ventricle, or the left ventricle, or biventricular, or a separate entity where you have an isolated right ventricular dysfunction, typically manifesting about 5-6 days after, could be because of an increased pulmonary artery pressures, pulmonary vascular resistance. Now, those patients, when you support the right ventricle, they get better. Late indications are rejection causing hemodynamic collapse. You can put ECMO, then bridge him to VAD and consider a retransplant. So to conclude, ECMO is an invaluable tool. It's a mandatory requirement in transplant unit, more so in lung transplant. Thank you for your attention.
Thank you very much for the wonderful presentation. And I'd like to ask, how about your, if you're going to place the ECMO before the transplantation, are they getting hypersensitized? And do you see patients with hypersensitized rejection more common in the post-op?
Well, I mean, that's a good question. You see, when you put patients on ECMO, you expose them to a lot of blood products, so that could sensitize them. But in our 16, we have not seen any particularly increased incidence of rejection.